Thank you for having me here today. I'm going to be covering a fair number of topics, exploring what's possible in the emerging era of big medical data. My general approach to talking is, number one, I'm going to tell you what I'm going to tell you. I'm going to tell you what, and then I'm going to tell you what I told you. Okay? So, in general, I want to share with you some of the opportunities and challenges we face with big medical data, show you some real-world examples, get you really excited about our potential. Then we're going to talk about why isn't everybody doing this? What do we still face to make this broad spread and widely available? So many great things going on, much opportunity, some challenges and opportunities to navigate. So what I'm going to tell you about where I come from, the Reed Street Institute. I'm going to talk to you about the problem, and then we're going to launch into analytics. So here's the problem. The next 4 or 5 slides talk about the problem we face in healthcare. This is a slide that shows on the x-axis the total healthcare expenditures for a number of developing countries. The y-axis shows life expectancy. How long do people live in these developed countries? Where's the United States? Anybody see it on there? Where is it? Still looking. Still looking? There's the United States.
Yeah. Wow.
So we spend a lot of money, and we have, at best, middle-of-the-road outcomes. So this is on life expectancy. So this is end of life that we're looking at. Let's look at the beginning of life. So these are newborn deaths per 1,000 live births for developing countries. Okay, you generally see an approximate correlation here. Where's the United States? There's the United States. So again, in terms of longevity, we're doing good. In terms of getting newborns into the world successfully, we're doing good as compared to other developed countries. Now, in full transparency, there are some people who push back on this and said, well, wait a minute. The United States gathers some of the best data in the world. Are we doing a better job of reporting and consistently defining what we mean by newborn death? Well, if the baby lives for a couple of minutes, can we say that it's not a newborn death? In some countries do that. So there is variability in these definitions, but the clear trend is obvious. We are so off the bounds in terms of standard deviation that there's clearly some issues. This slide shows the average reimbursement rates for Medicare patients in the United States. Some of you might be familiar with Northeastern States, the company. Thank you, the Dartmouth Atlas. This comes from the Dartmouth Atlas. They keep track of some of these data. So what these different numbers mean is different expenditure rates. So here in Western Texas, where there aren't a lot of people around, they charge a lot of money. If you look in, so this is urban, if you look up in the Detroit area in the United States, in Michigan, urban area, high expenditure rates. The expenditures across this country are very arbitrary. So it turns out it comes down to, in this area, there was actually a New York Times piece on this area of the country, where people show up to the doctor's office with shoulder pain to get an MRI. They're getting incredibly expensive care. There's a high degree of variability in care processes across the country, which leads to a high degree of variability in payment rates. Another interesting aspect of our healthcare system, and generally as industries mature and labor productivity, we see labor productivity become more efficient. Actually, healthcare, we don't see that trend. So what do we, for example, what we see in manufacturing is we've gotten, even though the labor, the Employment growth in manufacturing is decreasing. We're seeing increased productivity in that space. We're seeing increasing growth, dramatically increasing growth in healthcare. And as we add more people, those people are becoming less efficient. And so we have a problem with how the business of healthcare is being conducted. One final slide on one of the problems with healthcare. This is another dollars per patient, but what this shows is costs per Medicare beneficiary, average cost broken down by states. The y-axis is quality of care. It's a bit arbitrary, but there are some reasonable measures for that. You again see a general trend, which is very concerning, and that is the more money that we spend on healthcare, the lower the quality. And so we have a problem in this country. Our healthcare economy is approaching $3 trillion a year. If it were its own country, our healthcare system would be the fourth largest economy in the world. Now, again, these are general trends. There are lots of reasons to help people look at you and fix stuff. But one of the things that healthcare has been missing is information, metrics, measurements, data on how it's performing. We have entered the era where this data is no longer solely being captured on perishable pieces of paper. We've entered the era where healthcare information, healthcare delivery data is being captured electronically and persistent. And so we can begin to understand what's happening with it. We may find legitimate reasons for this. We may find some opportunities to improve. Part of what I do as a physician and a medical practitioner is understand how to use this data to improve healthcare outcomes and efficiency. One of the other analogies that I use is if the U.S. healthcare economy is a steak with a lot of fat on it, medical informatics helps to identify where the fat is so that you can get it. And that's one of the important things one of the important roles that I think leveraging data in healthcare can do, or leveraging medical informatics can do. So this is a description of the problem. Now about the Regan Street Institute, where I come from. Many of you, I see many familiar faces in the crowd, so many of you know this. The Regan Street Institute was established by a gentleman by the name of Sam Regan Street. He invented the front-loading dishwasher. He didn't actually invent the dishwasher. What he actually did was he perfected a manufacturing process for the seal that keeps the water from leaking out, right? Before Sam Regan Street, the low-cost dishwashers were the kind that you put the dishes in the top, right? Why? Because that way the water doesn't leak out. It was just a giant bowl. He figured out a way so people didn't have to bend over that way anymore and reach deep down inside. He was an excellent, prodigious process engineer who figured out how to save pennies on each of his dishwashers and made millions. When he had his first heart attack in 1969, went to the IVU hospital, he was cared for. He called the CEO down to his bedside and said, if I ran my business like you run your hospital, I would be bankrupt. And so in 1969, he created the Regan Street Institute, whose goal was to improve healthcare efficiency and outcomes. Now back then, they were even thinking about information technology and how data could be used. This is a picture of Sam, and that's the dishwasher. I kind of walked through this already. But medical informatics, physicians and healthcare providers using data has been going on at the Regan Street Institute since the early 1970s. We created one of the country's longest running electronic medical record systems that actually just transitioned in October of this year, began running in 1972, our own homegrown system. We also developed the world's largest and longest running health information exchange in Indiana, we have the world's largest and longest running health information exchange. What does that mean? Well, we have over 100 hospitals, thousands of different data sources, all sending data to the health information exchange in real time. All of this different data that is not standardized is standardized so that you can create a longitudinal, integrated, standardized repository. Today, that system has over 17 million patients in it. Indiana only has a population of 6 million. Why is there 17 million people? The information exchange itself is over 20 years old. People die, people are born, right? So, and people move in and move out. So we have a lot of patients in there. We have over 30 terabytes of medical data. Not so big in the big medical data era, but for a clinical data repository of its nature, there's nothing like it in the country. Nothing like it in the world. So I talked about 17 million patients, over 30 terabytes. We have over 6 billion discrete coded results on these 17 million patients. And it grows on a daily basis. So we use this data to provide, first and foremost, the information exchange began to support patient care. So remember all of those problems we're facing in our healthcare system? Back in the 1980s, a group of physicians and hospitals in Indianapolis said we need to take better care of our patients. Somebody said, what if in the emergency department, for patients who I've never seen before in my life, I as a doctor could see all of their data? People said, that'd be a cool idea. People at Reduce Resistance said we can build this. And so the information exchange began first and foremost to support patient care. Today, you know what the primary use case of the information exchange is? To support patient care. So physicians actually use this system today. So this is observational clinical data with all of its real world message, right? So it's real world. So do you like having anybody come over to your house at any time without cleaning it up first? No. Well, if you look inside the data repositories of these clinical systems, you're going to see that same mess that you all have at home right now that you're already cleaning up. Okay? So real world clinical data is messy, and I'll talk more about that later. But this data is used to support patient care. We have supported hundreds of different research projects, thousands of different publications leveraging this kind of data. So healthcare research, we also do a variety of process improvement things as well, but we won't focus on those today. What I do want to talk to you about is a concept that really covers a lot of what's going on in healthcare data analytics today, and that's called phenotyping. So folks are familiar with genes and the genotype. Well, what is the phenotype? That is the expression of genes. So I, as a physician, when I treat somebody's hypertension, their high blood pressure, I treat their depression, their asthma, I'm treating a phenotype. That hypertension, that asthma, that depression is an expression of their underlying biology. We can infer phenotypes from the clinical data. Making inferences from clinical data is 98% of what we do with medical data. Take this information and try to ask what is it telling us. So this is the Wikipedia definition of phenotype I've just described to you. By the way, I'm not sure who I need to give these slides to so that they're made available, but I'll make sure that happens. Interestingly, a phenotype, if you'll notice the second bullet point here, a phenotype isn't just about genes. A phenotype can be expressed as a result of patients' behavior, the exercise, do not exercise. It can also be expressed by their environment. So do you live in Beijing where the air pollution is causing inordinate amounts of asthma? Your environment may be influencing your health. So phenotype is not just about the genes. And we want to be able to incorporate not only the clinical data that I talked about, but increasingly bringing in environmental and behavioral data. So just to be clear, phenotyping is the practice of developing algorithms designed to identify specific genomic traits within an individual. That is a big, I think too abstract a definition. When I identify a patient's allergies, so when I ask a patient, are you allergic to penicillin? Yes. they now have a phenotype of penicillin. Okay? So it's as simple as that. I might also, so that's a very simple phenotype. At the other end of the spectrum, I might want to ask, does this person express, CYP32 gene under conditions of extreme stress? That's a little more complicated to define, may take some different types of inferences than simply a question and answer. So phenotypes take different shapes, but you're hearing this term a lot. In our health information exchange, in our clinical data, we cataloged them a few weeks ago. We have over 180 phenotypes. These are some of the phenotypes that we can extract from the data right now. Coronary artery disease, dementia, myocardial infarction. These are pretty typical things. If I were you sitting in the audience right now, I'd be thinking, well, what's the big deal? Isn't that what clinical data is about? Is saying you have myocardial infarction, you have congestive heart failure, you are depressed. Well, remember this data is incredibly messy, and remember that that messiness makes it challenging sometimes to even find and make these inferences. How are phenotypes used? We use them in a variety of purposes. We want to identify right now in the Indiana University Precision Health Initiative, we are identifying a diabetic phenotype. So we want to find very specific patients related to diabetes. We are very interested in a multiple myeloma phenotype, which is another specific disease. And so we use phenotypes to create cohorts. We use phenotypes, remember my allergy example? So in clinical decision support, the computer, when the physician's about to make a decision, give this patient penicillin, the computer can spit back, doctor, this patient's allergic to penicillin, I wouldn't recommend giving that drug. So based on their phenotype of penicillin allergic, you can leverage that inference to drive clinical decision support. Again, a very simple example. You can use phenotypes for case management and population health support. I'll describe some of those use cases in a minute. So I've already talked to you about the fact that the primary use case of this data is for patient care. So all of this data is used for secondary use. Very quickly, primary uses are for aiding in information and recall, conveying information about the members of the healthcare team, providing medical legal support, supporting the reimbursement process. Secondary use is everything else, okay? So I like making animation. So if this is all possible uses of data, and this is the primary use of that data, then this is secondary use, okay? You got it? I won't talk about secondary use. So I'm going to move now into the messiness of the data. We're going to spend a fair amount of time. So I want to talk to you about bias in the data. Bias is our number one enemy. In this example, is going to show you why. So we worked with the Indiana State Department of Health a couple of years ago. They wanted to understand comorbidities. So diseases that are associated with diabetes and obesity. Comorbidity is what that's about. So we generated a list of patients from our health information exchange. We identified using diagnosis codes, ICD-9 codes, patients with diabetes and patients with obesity. Okay, so just walking through this, and these, of course, are the combined codes. We started looking at some of the comorbidities, high blood pressure, which is HDN, hypertension, osteoarthritis, stroke. Then we looked at these V codes in the ICD-9 coding system actually represent something called body mass index, the ratio of height to weight. The higher your body mass index, the more obese you are. We saw a few numbers in this population, most of the numbers, but we suddenly saw a jump here, which represents a body mass index of 40 or greater. Whoa. But we have a lot of obese people in Indiana. Now, that may be the case, that may be true, but what represents this sudden spike in the distribution? Well, we did some digging on that code, and it turns out that medical coders who are trying to maximize the reimbursement should pay special attention to a BMI. A BMI of 40 or greater, a diagnosis of B85.4 gets you more money. So people, there is little incentive to enter these into the chart. So who's entering data into the chart? Either a physician who costs you a lot of money, or a nurse who costs you a moderate amount of money. You want to pay people to enter this stuff that they don't have to? This bitch. So there is bias in the data based on the incentives people have for that data. And this is a classic example. One of the things that we do when people ask us, hey, do you have data X, Y, and Z for us? In fact, just recently, the Indiana Precision Medicine Institute up in Indianapolis, they treat cancer patients. They wanted to look at how many patients were receiving genetic codes. And the first thing I asked them was, okay, you want genetic code data. Before I even look at the data, are all these codes reimbursed that you're looking for? Oh, no. No, not. Okay. So we pulled out the CMS, Center for Medicare and Medicare Services, reimbursement rate for genetic testing codes. And you saw an almost perfect correlation between reimbursement rates and the presence of the data in the information. Okay. So again, bias for the incentives for reporting that data. This is about observational clinical data. That's incredibly important. So phenotyping initiatives, if you're interested in clinical phenotyping, Vanderbilt University is managing something called the eMERGE network. They have a lot of interesting definitions to use. TKB, the Phenotype Knowledge Base, is another open initiative for folks to take a look at. So these are just some examples of people trying to put their definitions together to share their experience. Interestingly, I'm going to ask a technical question. There's no grading here today. If somebody had to tell me the difference between sensitivity, specificity, and positive predictive value, are you comfortable with it or not? I just want to know. So probably a small number of people. Okay. So these very well published, very well funded initiatives in the US right now who are creating phenotypes. By the way, Green Sequence Institute has 180 of 200 phenotypes validated in our community data. These folks are getting millions of dollars from the federal government. They're publishing something called positive predictive value. That essentially tells you if a test or a phenotype says it's positive, how many of them are actually positive? So how many of them, what's the true positive? Okay? That's very different from another kind of question you can ask. So that the positive predictive value tells you about the test. How accurate is the test? If the test says it's positive, how often is it positive? There's another question that people often want to ask, which is a different question. And it's covered by a measurement called sensitivity. Of the entire population of people who might have this condition, how well does the test cover that population? It's a subtle difference. I'm now 20 years into my discipline, and I still think about these differences, but they're different. And there's a tension between the two of them. If you want a high positive predictive value, your sensitivity is going to suffer. If you want a high sensitivity, your positive predictive value is going to suffer. These very well-funded governmental initiatives are getting outstanding positive predictive values. I haven't seen their sensitivities published anywhere. We have published ours. Here's an example of congestive heart failure. I've alluded to phenotyping being complicated. We've talked about bias. Now let me give you a very concrete example of, before I go into this, ignore this for a minute, I'm going to talk to you about diabetes. Well, if somebody has an ICD-9 code of diabetes in the medical record system, don't they have diabetes? Maybe, maybe not. Why won't they have diabetes? Well, a patient might say, hey doc, I've got diabetes. Doctor might know, they'll just tell you the patient has diabetes. The diagnosis code might be wrong. If a person is taking a diabetic drug, they may have diabetes. However, polycystic ovarian disease, which is a disease of infertility in women, is treated very commonly. It's treated very commonly by a diabetic medication. So you cannot just look at diabetic medications and say, oh, if you're on diabetic medication, you must have diabetes. Because many women with polycystic ovarian disease don't have diabetes, but they're treated with a diabetic medication. You could look at laboratory tests and say, oh, this person has an elevated blood sugar. Some women have elevated blood sugars during pregnancy but don't have diabetes afterwards. If you don't measure the blood sugar at the appropriate time, if you measure blood sugar very shortly after eating a meal, you may have an elevated blood sugar. It should be a false positive there. So laboratory tests, diagnosis codes, medications are all signals. To identify diabetes, we often combine with in order to make sure that we know that the patient has diabetes. You might even say for the astute clinician in the room, well, wait a minute, if they're taking insulin, they have diabetes. No, they use insulin to induce seizures for very severe cases of depression. So you can't even rely on that. So there's incredible complexity in this data that you need to understand. Congestive heart failure. If you look at a congestive heart failure diagnosis code, ICD-9, 50% of the time, it's wrong. Why is it wrong? Well, congestive heart failure is a poor pump. Your pump backs up. If your pump isn't moving fluid through, the fluid's going to pool somewhere, that fluid's going to pool in your lungs. Lots of things cause fluid pooling in your lungs. A cough, a cold, pneumonia cause it. Anytime a doctor sees fluid on the lungs, they say congestive heart failure. It's wrong. 50% of the time when you see that ICD-9 code, it's wrong. So we have to look. Here represents a variety of laboratory tests, clinical diagnoses, echocardiograms, imaging studies, all combined together in different ways to create that phenotype. Okay, we just published sensitivity, remember? Sensitivity is of the entire population. How well do you capture all that population? Positive predictive value is for the test, when the test says positive, how often is it right? So you can see a trade-off here. High positive predictive value, low specificity, low sensitivity. High sensitivity, low positive predictive value. We've not cracked this nut yet, and Vanderbilt doesn't want you to know that. So, interesting opportunities in clinical phenotyping for the research. I'll show you a couple of others. So I want to gauge the audience right now, so we have about another 32 minutes. How many of you feel like you've got 15 minutes of questions you want to ask me? And how many of you want me to talk until 5 minutes up? You have questions. Okay, so I will I've got a lot of material, but there's some of it just. Why don't I work towards maybe 10 or 15 after, and then we can start a dialogue? Is that reasonable? You guys okay with that? Okay. All right. Another example, hard to read. I will just say a variety of big data holders, including Medicare, Medicaid, Thomson Reuters, GE, put their data together. I'm not going to tell you who's who up here. We have a bunch of data sources. They tried to look at drugs and clinical outcomes. Drugs cause adverse events. Sometimes drugs cause good events, which is why we're supposed to be trying to. You can't read this, but this is a benzodiazepine. I apologize for being so small. Let me just click the highlights here. The drug and then an outcome, and then odds ratios. Here we have a benzodiazepine causing acute myocardial infarction. Benzodiazepines in multiple studies, well-controlled studies, do not cause acute myocardial infarction. Two of the data sources, and all of them suggest, observational clinical data sources, all of these, suggest that benzodiazepines cause acute myocardial infarction. They don't. This caused people to do the actual controlled trial. They don't. This is a bias in the data. Up here we have Coumadin, a blood thinner. If your blood gets thin, you're more likely to bleed. You with me? Coumadin, which is warfarin, and bleeding. 4 of the 5 data sources said no. Coumadin doesn't. There is bias in the data, and you have to know how to. If you take a simple phenotype with low sensitivity or low positive predictive value, you're going to wind up with false positives or false negatives. False negative, false positive. So it is important that you understand your data. For those of you in the room interested in the future of phenotyping, this is the model that I've come up with. There are 3 dimensions to thinking about phenotyping. And again, I think phenotyping is making inferences out of clinical data. So I think this is where the data scientists in the room, if you're going to be working in healthcare data, these are the methods that I think you're going to be working on. So what are the dimensions of thinking about phenotyping? What's your data source? Clinical, behavioral, or environmental? What kind of data are you going to be bringing together to understand health outcomes? There's the dimension of data standardization. I've talked about ICD-9 codes, diagnosis codes, procedure codes, medication names. Those are often coded, discrete, standardized. Much more clinical data is unstructured. Physicians still type in free text notes. You still have a lot of free text. And so extracting the hidden, locked data in unstructured data is a challenge. So we've got sources of data. We've got the standardization of the data. And then we have the methods that we're going to be using to extract them. Are we going to be doing ad hoc, supervised, user-based rules? Are we going to be developing machine learning, analytic rules? Are we going to be using combined? So this is the dimensionality of the future of health data analytics. You can put, and right now, interestingly, we are in this front left box. The entire rest of the cube is really undefined territory in terms of understanding what works. So there's a lot of, again, putting on my research hat, there's a lot of opportunity here to better understand methods for health data. So now we're moving on to the real world experiences. We have built a natural language processing platform to identify this unstructured, free text, hidden, locked-in data. So peripheral arterial disease of the peripheral arteries, is diagnosed by something called an ankle brachial index. You take the blood pressure of your arm, you take the blood pressure of your ankle, you do a ratio. In fact, almost all electronic medical record systems today, they don't have a standard place to put the ankle brachial index. So it's an unstructured data. We built an algorithm to extract that data. And to a computer scientist, or maybe to a data scientist, this might not be very exciting. To the lead of cardiology at the Mayo Clinic, he said, we're publishing this. Because nobody's done this. It takes 45 minutes on average for a chart abstraction nurse. Nurses whose job it is to go through paper charts or electronic charts and find the data necessary. It takes 45 minutes. With something like this, it dramatically reduces time and improves the accuracy. So we don't even know how prevalent peripheral arterial disease is in the country. Why? Because the data is locked in unstructured data. So seemingly simple, uncomplicated things like it's a number. Get the number from the free text. Which numbers are important? And build a tool that doesn't put on that. This is a project I worked on with one of my graduate students. Again, this is going to be another example of those seemingly simple sounding things. So, a lot of cancer diagnoses are made and described in pre-tested. Cancer is a reportable condition to public health to states because cancer is a terrible disease and we want to understand its prevalence. It takes somewhere between 9 and 18 months for a cancer case to be reported. So the timeliness is not great, and the cost, the time to find those cases is expensive. So 45 minutes for peripheral arterial disease. I think the estimate is it's about 17 hours to abstract a full cancer case. Why so much? There are actually 220 fields in the official SEER cancer registry that need to be filled out. A ton of data, a lot of it. So what we did is a very small step in this process is we said, you know what? Surgical pathology reports have a lot of cancer cases diagnosed in them. Let us develop an algorithm that simply says, is there cancer mentioned in this report or not? Yes or no. If it is mentioned in the report, I don't care what cancer it is, melanoma, colorectal cancer, don't care. If it's yes cancer, send it to the cancer registry. It's a very automated process. Again, cuts down on time. So this, our study, which again wasn't overly sophisticated, was picked up by Forbes. Why? Because we identified a clinically valuable process that was incredibly costly. So we improved the healthcare outcomes for member family history and efficiency of the process. So this was in the Journal of Biomedical Informatics. What did we do? I won't go through the methods and techniques because that gets fairly technical. I'm happy, love talking about the technology. One of the cool things we found, so just one cool thing, so this is the fun stuff. I think neural networks are fun too. One of the fun things we found, so the word sheet. If you see the word sheet in a clinical pathology report, it's probably cancer. You know why? Does anybody know why? Anybody have a guess? Sheet? What is linen on my bed after the cancer? Turns out that most cancers, cells lay out in sheets. They clump together in sheets. And so pathologists say sheets of cells. It's very typical of cancer. I didn't know that. We also found in looking at the weight of the features of these different words, the word left was more indicative of cancer than right. We dug in, it turns out that most of these were breast cancer. It turns out that 8 or 10 years ago that there were some pathologists who found breast cancer happens more likely on the left side of the body than on the right. And our machine learning techniques found that out too. So we were just taking their seat. So again, technical details, would love to get into this level of detail in 45 minutes. Can't do that. You all will have the slides, you have the reference to the paper. The interesting part about this is, so for 3 years I've been using machine learning algorithms now. Not sophisticated machine learning algorithms, the machine learning algorithms that colleagues of mine at MIT when I was there began developing in the late 90s. Those algorithms that have been around for 20 years work amazingly well. Area under the curve, sensitivity, specificities above 95%. I'm not doing innovation in machine learning. I'm using machine learning and applying it in the right way. There's so much opportunity to be had here. And why? What's happened? So A, we have a ton of data now. We have a ton of messy data we don't know how to use. So now we can start using these techniques, and we actually have hardware now that allows us to process and build these models. But my message from the last 3 years of research is don't wait. So I have to preface this. There's computer scientists in the room. I don't want to offend anybody. If you need to get promotion and tenure, please do create a new algorithm that gets you 1.2% greater accuracy. But if you're interested in having an impact on the world, stop trying to innovate machine learning, please. Figure out what clinical diseases can benefit from the algorithms that exist. Because I guarantee you there is a Nobel Prize, Peace Prize in the making for the people who find those algorithms. And one of the things that I'm spending much of the rest of my career on is building a platform that can run as many algorithms at one time for the tens of thousands of conditions that we find in our system. I believe there are important algorithms that can help physicians who are overburdened. My wife is a family physician who sees 40 patients a day. She shouldn't be burdened with having to say, well, where's that lab result? Where is it? What is it? What's the normal range? I can't remember. Let me look that up. Computers should be doing it. Is there a case of cancer in here that I have to report for public health? I shouldn't have to worry about that. Computers should start disintermediating the human so that the humans can spend time with other humans, diagnosing them, caring for them, interacting with them like humans. Letting the computers do a lot of this grunt work. And the computers can do a lot of this grunt work. So, we have a notifiable condition detector. I've got about 5 more minutes again. In addition to cancer, there are about 60 diseases in Indiana that are automatically reportable to public health. Since 1999, we've been running a system that automatically detects those. Initially, it started as SQL rules. We moved to expert system rules. And last summer, with the help of a computer science graduate student who knows nothing about reportable diseases, but knows everything about machine learning, she built an algorithm that you saw tonight. She built an algorithm that detects 4 diseases better than anything we've built for 15 years based on some of that. So she's built an algorithm that has a 98% sensitivity, 99.9% specificity. That means there's no false positives. She did this without any knowledge of reportable diseases. She had training and test sets going back to 1980. So she had an off-the-shelf algorithm. She had lots and lots of data, and she had a physician who had a real problem. That's the path. This is more detail. I'm going to burn through this. If you catch it, great. If not, don't worry about it. This is what the actual healthcare transactions look like today. It's called HL7. We remove stop words from our transactions. We remove stem words. We stem the words. Remove the endings. We create a feature vector from these. We remove the stopping and stemming from the feature vectors. We sort them. We count, tokenize. We count the numbers of them. And ultimately, what we're left is this bottom row is what we feed into our algorithms. That's our method. We did this so one of our cases, our salmonella use case, we looked at positives and negatives, and again, the accuracy specificity was, so the specificity here was 94%. Sorry, this was done by an epidemiology grad student 2 years ago. This wasn't last summer. So the model, we only used, I think, 4 features to describe it. So the specificity isn't at the 99% level. Excellent sensitivity. This was actually a study, a very limited study that said there's something. Because we only used 4 features in a model that that produced outstanding results. We've got about 4 minutes left. Let me just take a quick look at my slides to make sure I get to where we want to be. Here's the last story I'll tell you, and then I'm going to end with some. So I hope you're all excited and interested in the possibilities. Right? That was my goal. There's some real stuff. My last exciting story, and then we're going to talk about some cautionary. So these are the emergency departments in Indiana that the Health Information Exchange receives data from. We get over 2.5 million emergency department visits a year. One of the things we did is we wanted to predict what patients were at risk for overusing emergency departments and predict them before they become overused. So this will be a test, and you can read the graph that has a log scale on it. What do you think the maximum? What do you think the maximum number of emergency department visits a patient would have? For those of you who've heard the talk before, one person, single person, over 3 years in Indiana, how many times do you think they went to the emergency department? Maximum, number one person. Any guesses?
7.
7, 300, keep going. Less than 1,000, 385. So this is what I like about my job. The data tells an amazing story. So this person had 2 diagnoses that completely explain this. We're going to need 5 more. What's going on? First diagnosis, they had sickle cell anemia. It is a chronic disease if not managed appropriately. You can get into sickle crisis, very painful. You run to the ER to get pain medication. Legitimately so. These aren't drug seekers. These are people that have real disease. 385 times in 3 years. That's crazy. Second diagnosis seals the deal. Their second chronic disease is schizophrenia. So they have a mental illness that prevents them from managing. This person's running all over the state, known as a frequent flyer to the emergency department, but not known to be that kind of frequent flyer. Get them into a care management program. So this is some of the cool stuff that you can do with data like this. Once we just did an analysis of how patients moved around the state, we built the logistic regression model. I love random forest. Random forest algorithm was made for messy medical data. If you have lots of messy medical data, random forest is your friend. For cancer case identification, for emergency department utilization, for predicting who's at need for a social worker referral. Random forest works amazing well. Out of the box, using Weka, using R, using SAS, works too. So with that, and at my time, now comes my cautionary tale. This is amazing data. This data was put together for, first and foremost, for clinical purposes. So the people who initially said, I'm willing to put my medical data into this repository are the chief executive officers of hospital systems. The way this data works, and part of the reason that a Regent Street representative is here talking to you today, is back in the 1980s, the hospitals said, we trust Regent Street's capability to manage data. As the acting director of the Center for Biomedical Informatics at the Regent Street Institute, I have 2 competing interests. I want to see thousands of papers published on this data. I want to see academic careers made. I want to see students learn from this data. If there is a data breach, the Regent Street Institute is no more. One headline to the Indianapolis Star that there's been a data breach from this data, and it all goes away. Why? Because the chief executive officers of these hospitals were putting this data in, first and foremost for patient care, because it does improve patient care. They also understand it's being used for research. They care about patients. They care about their business, their enterprise. And so, as people have come to want to use this data, we very often have to say, hold on, slow down. It has to be de-identified. How are you going to protect it? Do you understand HIPAA? There are many, many layers to the process of getting access to it. Not because Regent Street doesn't want to see you successful. I want to see everybody successful. One of our projects a couple of years ago, we could have had a potential breach. We could have had a potential graduate student fly to China with data on it. We had processes in place to detect it, and we're able to prevent that from happening. But we're very, very sensitive to this issue. Incredible opportunity, incredible sensitivity. We need to do this. So, what is the process for getting access to the data? Generally speaking, we say minimum necessary. Can it be de-identified? Ideally, we prefer storing the data within the Regent Street firewall on a server setup. We've also worked with Indiana University to create a karst environment that supports the HIPAA regulations to get data there. That's just recently find that's been very effective and useful. Investigators also have to sign away the first child. But there is a very complicated agreement that you have to sign that essentially says, even though it's a de-identified, even though if I looked at this, I can't tell who the patients are, you still have to protect them. Why more than that? Well, research after research after research has shown you take this de-identified data and combine it with some other data set, and now you can identify it. And even if you had the greatest of intentions, that hospital CEO doesn't care. We're done. So there is this incredible balance that we must strike. And so we are very deliberately, the karst environment was the first one where we deliberately said, we've got to get this data out. And it's the process that we have right now that I think would probably benefit most people in this room. We are working on new processes for how we might be able to relax the expectations around de-identified data. But again, in the background, this is not Regan Street saying, no, you can't. This is Regan Street saying to the hospital CEO will be in this. And so there's this incredible tension. So with the excitement comes the cautionary tale. Now let's open it.
How are you factoring the bias in the data? Have you guys been thinking about how the payment form should Medicare will influence what this is?
So I would love to study that. We've talked internally about it. So a general pattern that I've observed. So I have a sliver of research that I work on. A lot of my time is spent on keeping the system running operational. We need people like you asking those kind of questions and doing a study. I think it would be amazing to look at, how do incentive plans, payment strategies influence the data? So it would be very interesting to take a look at.
How about the bundle payment? I mean, it's going to reduce the bias of the medical.
I mean, the short answer is I don't know how it's going to affect. Human beings are infinitely creative at getting around things. So, I mean, I've just seen so we implemented computerized physician order entry that we thought was easy, slick, and fast. And physicians figured out that they could have the unit nurse and all of the. So how human beings will code and optimize and game the system. So it turns out, another story that I didn't put on here, but there's 1,000 stories like these. It turns out that a patient who comes in with diabetic ketoacidosis, so they're out of control with their diabetes, they have an infection, they've broken a bone. The #1 diagnosis is dehydration. You know why? Dehydration, for whatever reason, pays incredibly well. And so when you look at a list of diagnoses, and many of these systems only keep the top so many, the most important critical diagnosis that you wanted isn't the top one. That's, again, another example of reimbursement bias. But human beings find a way to optimize the hidden latent class variable, right? Finding those latent class variables is a challenge. So I don't know the answer to how bundle payment is going to impact the system.
Are you saying that it's 100 hospitals sending the real data patient to the health exchange, right? So each of these hospitals, they have a different EMR system.
Yeah.
So how do you consolidate those messy data?
So one of the other things that Regan Street is actively involved is we have some of our faculty are on the board of directors of HL7, which was the healthcare data standards. Another major data standard called LOINC, which standardizes all clinical observations in laboratories. We created it for Regan Street Institute. It's the most broadly used health data standard across the world. The Regan Street Institute maintains that. So in the Health Information Exchange, prior to creating some of these standards, we realized, gee whiz, we need a standard. We've got to standardize them to some code system. So in the Health Information Exchange, we have 3 to 5 full-time employees who do nothing. We get about 2 million who do nothing but We get 2 million transactions into the information exchange a day, at least, on average. Most of those will have been mapped to a common term dictionary. But there's an exception queue. So every day, if we don't recognize the clinical code that transaction comes in with, it gets kicked out to an exception queue. And 3 to 5 people are sitting there doing nothing but saying, what is this code and how does it map to our standards? And they're just doing that all the time. That's one of the hidden costs in an integrated, fully interoperable health system. There is no automated way around it. Every year we publish a paper on automated mapping, and it's still not there.
Can you talk a little bit about feature selection on the machine learning models?
Sure.
And given kind of unlimited compute, you know, it's going beyond the little feature.
Sure. So, you know, so there's a lot I could say about feature selection. I'll tell you what we do. We actually, we've done a couple things with the random forest algorithm. So first of all, random forest would take care of feature selection itself, and most of the time we just let it do the feature selection, which is why I like it. Sometimes though, there's just too many features, and so we'll use lasso. Sometimes we'll just use simple information gain to prioritize those features. You don't have to be overly sophisticated in this game. There's so much signal in there that you don't need to necessarily look at correlates or those sorts of things. But I will, no, we don't have any time to go into that. So I will just say that the simple approaches generally work well. We have looked at, in fact, that paper that I quoted there, we actually looked at different feature selection methods. And what we found was the simplest information game worked just fine. So we actually constrained the random forest down to 20 variables using information game, which is a little bit of a cheat. The computer scientists didn't like it very much. It took us too long to kind of call it as a editor, but it works. And so I am all about figuring out what does work now. Very few people, like I said, you can either create a novel methodological innovation or you create a novel application. That information exchange data is the biggest novel application I've seen in my life. So if you want to create novel methodologies, knock yourself out. But I think the big win is in the novel application. Go for it.
Now, do you think that the future of clinical is going to depend more on verbatims than necessarily having more and more refined like checkboxing or like
Like free text and structured text.
yeah.
Thank you. When I saw patients 8 years ago, oh sure. So she asked, do we think that the medical profession is going to rely more on verbatim text, sort of free unstructured text, or are we going to go to more structured, check the box, fill in the blank? There's so much I could say about this. 8 years ago, when I saw patients, I would walk in the room, I'd talk to the patient, I would examine them, we would interact like human beings. We would leave. I would dictate for 90 seconds, have a nice half to 3/4 of a page note in human language, and be done. And anyone who saw that patient afterwards would understand what I did. Today, if you come in with a sore throat, I'm going to click, check, punch, complete, and there's going to be a 6-page standardized note in there for what should be a 1/4 of a page. The EHR systems have taken us in a horrible place. And I'd say this to anybody who wants to hear it. We will be going back to verbatim, I guarantee it, because computers are getting smart enough where you walk into a room, the computer is going to be listening to what's being said. At the end of it, doctor, you forgot to ask her about her smoking status. Oh, what's your smoking status? The computer will learn to read that and become much more. We have saturated the data capture capability of these high-paid data. And I speak, and I speak not only as a physician myself, but my wife, who sees many more patients a day than I did. 5 years ago, when they got an EHR, she was home an hour after clinic was ended. Now she comes home and she has 3 to 4 hours of notes per night. It's not an exaggeration. She's literally in bed beside me, working on her computer. This isn't sustainable. Physician satisfaction is plummeting, and it can't work. We have flipped the human being to accommodate the technology. The technology has to accommodate the human being. So there's a lot of work, I think, going to be done. I think the first step to getting to that vision where you just walk in the room and computers everywhere, one of the first steps is I think we are going to go back to more transcription. And I think we are going to begin extracting more and more data from free text notes. So yes, it's coming. We can't sustain it.
Do you see a time when the computer does the history?
When the computer asks the question, absolutely. I mean, we already have one of, some of the members of our team have created what's called a pre-screener form that's customized for the patient's history. Now, that pre-screener form today can be administered both on paper and digitally. The paper form, it gets optical character scan read after the patient fills it in. And then for those offices in federally qualified health clinics that have no money for sophisticated EHR, the physician gets another piece of paper that responded to those patients' notes with the clinical reminders on it. It can all be done electronically, but yes, there are lots of history-taking techniques that are being built. So that's an example of disintermediating the human workplace. However, as a physician, I will tell you, I think we're a ways away from the entire history being captured by the computer because there are subtleties. The computer may not be able to look at you and say, you know what, you're sweating a little bit, your push just a little long. So that's going to make you want to ask them, right? There's metadata about you that still the algorithms can. But it's coming. We'll get back to you.
So just a question about funding the potential. How difficult is it to get funding when you present a proposal for a national funding for reapplying something that already exists in an innovative way as opposed to saying, you know, it's great.
That's an excellent question. Computer science generally pays for people to create something, a new methodology, medical application. On the National Institutes of Health side, the NIH side, applications for work. And that's typically where medical informatics has lived. Now, I will say that I've been on a couple of NSF grants. I'm on one right now with Saram, I can't last name now, but and so we've been doing some work, but that issue constantly comes up, and even promotion and tenure, right? So you get promoted by creating the Smith algorithm, right? You don't get promoted by saying, you know what, I took the Jones algorithm from 10 years ago and saved some people's lives. Right?
And that's going to change that perception.
I don't know. I am an aerospace engineer and a physics minor. I'm not a computer scientist, and I was promoted and got tenure as a medical informatician at a medical school. I don't fully understand that culture and that culture. When I got in 3 years ago, when I went heavy hog into machine learning, getting papers published in computer science literature, the pushback I got was exactly this. Where's the new methodology? My response is, my God, we're saving lives. Doesn't that matter? Well, give us a little bit of methodology, please. So it's a different culture. It's frustrating me because I don't understand it. It's a legitimate culture because we have to create new innovations. No question. But finding that balance has really been, I think, how does IU School of Medicine in Indianapolis collaborate with IU Informatics and Computer Science Bloomington? Crack that nut, and you got yourself a career.
What do you see happening in EHRs and HIEs with capturing social determinants of health? Because I know that most EHRs today aren't big on capturing that data. So where do you see that heading?
Sure. I'll just, before I answer that question, I'll say, you guys have asked some of the most important, insightful questions. This is a great group of people because the questions you're asking are spot on, incredibly important issues. So, social determinants are. Oh, I'm sorry. The question is, given the future of EMR and HIEs, where do behavioral and environmental determinants of health fit? How do they fit together? So, today, I'm going to sound like a broken record. Today, the healthcare system is not incentivized to capture that, so don't expect physicians or nurses capture that until we prove that knowing that information will actually improve healthcare outcomes. When there's a proven clinical reason to do it, and the federal government will pay for it through Medicaid, then it trickles down to all the payers. But, so where are we right now? We're doing a ton of work in this right now because we believe that social determinants, environmental, behavioral determinants are incredibly important to healthcare. So we have built a linkage in our health information exchange. Every patient gets geocoded and a census block and census tract assigned to them. We have collaborated with an organization called the Polis Center up at IUPUI. They capture a lot of social determinants data. One of our Robert Wood Johnson Foundation grants right now is building predictive models to say, who needs diabetes education? Who needs social work referral? Do it with clinical data alone, then add in the environmental and behavioral and see how your algorithms improve. We're doing that very test right now. We're hoping that it shows great promise. And if so, people will start taking notice and oh, maybe we should improve this and better improve it. So I think it's coming. We built that linkage because we think it is important, but it's not something that you see generally.
So a slightly facetious question, but I'm imagining two alternate futures. One in which the healthcare systems find out they can replace physicians with a machine learning driven hologram that can, 96% of the time, accurately diagnose and treat patients, and we all then visit with a hologram, then technically it's the performance goes up and the expense goes down. And then maybe another future where physicians are enabled by, surrounded by a constellation of technological innovation that can actually help them. So when you go and see the doctor, you get this amazing value add from the human interaction and what the doctor and you together can learn from the data. I kind of like the second one better, but where are we heading? Are we heading towards that dystopian kind of with doctors being pulled out of the loop, or are we heading to the other one?
I don't know that it's an either-or proposition. I'll tell you one thing that I know a major EMR vendor is working on right now, reading mammogram. Okay, it's kind of a bread and butter job that radiologists do, high volume, kind of boring, very focused process. They are looking at building an image detection algorithm that finds the, partitions the very obvious, simple negative ones and actually send you them for an Indian radiologist because they're so much cheaper. So you have, this is right now, there's conversations with the FDA going on to say, if our algorithm is accurate enough to say, yes, this is very clearly negative, can we just ship it off to a cheaper alternative to confirm and then keep all of the more complex ones? So that's an example of disintermediation coming in. But to go, I don't have enough time to talk about the complexities that you discover in clinical care. There is an incredibly long tail of one-offs. Yes, I can follow a diabetic regimen, but it turns out that this patient can't afford the cab fare to get to me once every quarter. And so they're not following the treatment protocol. The individual variation in treatment and the unpredictability of, okay, you are fine, others will be fine. That's incredibly hard to build. I think that disintermediation will begin with simple things. One of the areas, again, that's an area of research on, so I'm biased, so I'll just admit that, public health case report. People generally don't die if a report is missed, because there's so many other safeguards in the system that get found otherwise. But it takes up a lot of time in clinic to do that. So there's an example of kind of a necessary function that needs to be done that can be automated at that time. And so thinking about what are those other places, I don't think we'll ever get to I'm speaking to the hologram. Now, I might be speaking to the human being in India through a screen, right? But that's still like some form of human interaction. By the way, even if we do go to the hologram, I don't think it's happening. I think what you heard me describe today with access to really large data, very few places in the world can do it. And so until we get a massive body of data and literature that pushes up to the policy level where we think about, okay, how should we use it? Is this good enough? 95% good enough on the draft grant? Don't know. Let's start debating in Congress whether or not we should fund this through Medicare. Medicaid. That entire process of changing the healthcare system, that's okay. It's not, I mean, the technology is the easiest part of it. It's the implications of that technology on the human condition make it challenging. So I just wanted to do a time check. I believe we were scheduled from 1:30 to 2:30. It's now 2:40. I don't know if there's a timekeeper.
Yeah, so we actually have the room next door, which is a little smaller, for anybody who maybe wants to stay around for a little bit, if you're scheduled for next, to have a little bit of discussion going. So I think we do have to get out of this room now, but next door in LA 101 for anybody who do that. Thanks for coming.